42-year-old female, hypertensive since the last 7 years, on irregular treatment, diagnosed with type 2 diabetes mellitus 2 years back, on on OHA with uncontrolled blood sugars, presented 4 months back for a
Wait, wait,
history of.
wait, wait, wait. The first part of the story, she's 42-year-old, non-hypertensive.
Sir,
How does, what are the presentations of hypertension?
hypertension. Um, mm, Presentations. Um, Hypertensive retinopathy. Uh,
Commonly, the presentation is incidental recording of blood pressure for some other purpose. Routine evaluation. Second group of patients are patients who come as an emergency because of endocrine damage like kidney disease, pulmonary edema, hypertension, encephalopathy, cerebrovascular accidents and complications. So this is how they present commonly.
yes,
So
sir.
routine screening is the common one.
Yes, sir.
You get a headache when there is hypertension, encephalopathy. Otherwise, commonly they come with asymptomatic stage. So usual presentation is symptomatic, routine checkup reveals it. And subsequently this patient became diabetic. Okay.
Sir.
So what will be the best drug for hypertension in a diabetic patient?
Um, um, uh, Angiotensin receptor blockers.
Yes, ACE
Or
inhibitors are the best. The mechanism of action of ACE inhibitor is to protect your kidneys from damage. And how does it do that job? It is not the lowering of blood pressure per se, but it decreases the pressure inside the glomerulus. So on the one hand, it reduces the blood flow to the glomerulus. At same time, it increases the outflow. So intraglomerular pressure decreases. That's how it protects the kidneys. This effect is independent of effect of reduction of blood pressure preventing kidney disease. Is the point clear?
yes, sir.
There, that's okay, fine. Now, okay. Now the patients come for
Presented with 4 months back with the history of pyoderma
pyoderma.
on
Okay.
the left lower limb,
Okay. So
followed by
this is
edema.
a diabetic patient who presents with skin manifestations. So what are the common skin manifestations of diabetes?
Um, Skin infections like
So
carbuncle, fungus.
common skin infection undergraduate students remember is A, B, C. Abscess, boils, carbuncle, all produced by staphylococcus. It's a group of infection. Very common. Yes. Other manifestations are
The manifestations, um, cellulitis.
two manifestations you must be specific for diabetes are one is necrobiosis lipotica diabeticorum on the shin. Number two is what is called as granuloma
Necrosis.
annulare. These are two specific things. Then you can have acanthosis nigricans is a sign of insulin resistance. You can have skin tags, a sign of insulin resistance. You can have abscesses, lipodystrophies at the site of injection of insulins. You can have intertrigo and different types of fungus infections in diabetic patients. And there are specific things for diabetes like diabetic dermopathy, pigmented pitted lesions on the lower limbs predominantly. There's something called as diabetic bullosa, bullous lesions in the toes. Okay, so these are common things in diabetes. Vulvovaginitis and balanoposthitis goes without saying. Okay, anything else? You may
Uh,
get lipomas, you may get xanthomas. Xanthomas occur in 5 different forms. One is xanthoma palpebrarum, 1, 2, tuberosity, Xanthoma tuberosum. 3. Xanthoma eruptiva, in eruptions in the buttock. 4. Palmaris, in the palms. And tuberosa tendinosa, or the tendons. Palmaris, eruptiva, and Xanthoma palpebrarum. So these are the 5 different forms of xanthomas you may get sometimes in these patients. In addition, you can have cellulitis, you can have gangrene, such things do occur. So this patient presented as abscesses. Pyoderma. Okay. Then
Uh, Edema was initially noted on both lower limbs, but progressed over the next 4 days to involve the face, abdomen. She also developed
so
orthopnea.
rapidly developing edema, anasarca, and patient developed
Orthopnea.
orthopnea. So in this background, you have to think about left heart failure. Okay, then
History of oliguria is positive. Then,
history of oliguria was present. Okay. So which system is affected in this patient?
sir, kidney.
Kidneys are affected. So what is the possible type of kidney disease in this patient?
Um,
Is it a chronic kidney disease or acute kidney disease? Or acute on chronic disease?
Sir, acute kidney disease.
Acute kidney disease commonly presents as oliguria, edema, and puffiness of face. How does chronic kidney disease manifest?
Chronic kidney disease, oliguria or dysuria, then uremic encephalopathy. Then
The common presentations of chronic kidney disease are: number 1, polyuria, because tubules lost the function, so they go for polyuria. Number 2, they present as anemia, so pallor. Number 3, very much symptomatic as far as gastrointestinal system is concerned: anorexia, nausea, vomiting, hiccough, aversion for food. Fourth group of symptoms will be pertaining to your renal system, renal osteodystrophy, bone pain, muscle pains. So these are the 4 common presentations of chronic kidney disease. When such a person walks around the community, he may be asymptomatic, possibly minimum amount of dyspnea because of anemia, anorexia, he just ignores it. One fine morning, when he gets into some infection or something that precipitates, then he comes with acute renal shutdown like picture, edema, oliguria, puffiness face. So that is also possible in this particular individual. So what are the common precipitating factors of acute kidney disease over a chronic kidney disease?
sir, diarrhea.
Diarrhea, very good.
Then
So volume loss, diarrhea, vomiting, volume loss.
volume loss. Then use of NSAIDs.
NSAIDs, excellent. Not only NSAIDs, nephrotoxic drugs, aminoglycosides, whatever it is. Very good. Okay.
Then other
Infection, very very common. This patient had pyoderma, then he developed this edema. So infection. Any other?
then vasculitis.
You see, people who are using old persons, they have what's called obstructive uropathy, prostate, stricture, phimosis, paraphimosis, bladder neck obstruction, CA infiltrating the urinary system, like say cervix, malignancies of the pelvis. So all of them will produce obstruction. Another group of condition will be characterized by stones producing acute on chronic. So acute on chronic majority are reversible factors: dehydration, infection, obstructions, stones, okay, drugs. So acute on chronic. Here is a situation where patients come with acute, but there is a history of pyoderma. So pyoderma and edema, what was the interval? They came together or
Uh, uh, they came after 1 week, sir. After
if it is
suspension, 1 week.
2 weeks, 3 weeks, then we will suspect acute glomerulonephritis appearing. Acute glomerulonephritis appear 2 to 3 weeks after a appearance of infection. That interval is not here. Okay, right.
And no history of gross hematuria, no history of no history of intake of over-the-counter painkillers.
Just a minute, just a minute. Okay, you tell me what are the situations where you get gross hematuria?
Gross hematuria, sir, tumors
No,
or
no, no. When you discuss about kidney diseases, somebody gets infection, immediately they get hematuria, gross hematuria. That's how you diagnose IgA nephropathy, one of the commonest nephropathies. So IgA nephropathy you diagnose when there is a hematuria appearing along with infection. Unlike in glomerulonephritis, there is a gap of 2 to 3 weeks. IgA nephropathy appears along with infection. Okay, but not applicable here because there is no hematuria. Carry on.
sir, history of intake of painkillers are present prior to the event.
Nature of painkiller is not known, right?
No, no, yes, sir.
Okay, fine.
Uh, she was detected to have a high BP at the time. Started on some medications.
When
Uh,
when
sim- Hello, sir.
when was hypertension detected? This admission or previously?
On admission, sir.
Now, for first time.
No, she was already hypertensive for past
Okay.
no
Now it was
past 10
found to
years.
be
Uh,
uncontrollable hypertension. Am I right?
yes, sir. Yes,
Okay,
sir.
uncontrollable hypertension now. Okay.
Started on some medications. Symptoms improved over the next 2 weeks. She had remained relatively asymptomatic for the last 4 months. Now
Okay.
presented, now presented with diarrhea and vomiting for 6 days. 10 to 12 episodes of profuse watery diarrhea per day. Then no blood or mucus in stools.
Mm.
3 to 4 episodes of vomiting per day. Mild uh, abdominal pain. Mild vague abdominal pain is present.
Okay.
Then
No fever.
no, no fever.
Okay.
History of increased urine output is present.
Okay. So here is something that precipitated an event in this patient, and subsequently there is no urine output and dyspnea. Okay.
Yes,
So
sir.
history, classical history of acute and chronic. Okay, carry on.
History of altered sensorium for 1 day.
History of altered
Then
sensorium for 1 day.
no history of weakness.
Why do people get altered sensorium in the background of diabetes?
Uh, Diabetic ketoacidosis.
Ketoacidosis, yes.
Then uh, hypoglycemia.
Hypoglycemia, then
Then hyponatremia.
hyperosmolar non-ketotic coma. They may have lactic acidosis or cause of coma like in any other non-diabetic patients. Why do people get altered sensorium in hypertension?
Hypertension, altered sensorium. Maybe cerebrovascular accidents.
One possibility is there, yes.
Then hypertensive encephalopathy.
Hypertension and encephalopathy. That's possible.
Then,
Why do people have altered sensorium in a kidney disease?
sir, because the kidneys are functioning properly, can lead to accumulation of toxins
What's
like
that called? What's that called situation?
uremic encephalopathy.
Encephalopathy. So they may be going for uremic encephalopathy. So we have a differential diagnosis here, plenty of them. Okay, carry on. Very good.
Then past history of 2 abortions are present.
2 abortions. At what month is that?
Then family
At what month was the abortion?
it is not given.
Now, why is it important to you?
Sir,
People getting abortion the first month, second month, third month. How does it matter? How does it differ as far as the etiology is concerned?
um,
In syphilis at what
sir,
month? Toxoplasma what month? Apply what month? SLE what month, like that? What month? Anyway, we do not know, so we leave it there. Okay, carry on.
Sir, family history, there is a history of CAD in father.
Father had
Then,
coronary
no,
artery disease.
yes, sir. Then, no history of renal disease in family.
No history of renal disease in the family. So, what are the familial renal diseases you know of?
Sir, polycystic kidney disease.
Okay. How does it run in
Then,
families?
sir, it is also uh, dominant and recessive autosomal.
Autosomal dominant and recessive both are present. So, what
Yes,
is
sir.
the basic difference in the dominant and recessive pattern? Dominant
Sir,
is what type of transmission? Horizontal or
sir,
oblique?
sir, dominant is vertic.
Vertical transmission. And autosomal recessive is
Um, also recessive is um, oblique.
horizontal transmission. And what are the chances of getting the disease in next generation as far as autosomal dominant is concerned?
Sir, next generation 100%, 50%.
50%. What about the autosomal recessive?
Sir, autosomal recessive, uh, autosomal recessive,
25%. Okay.
25%.
So 25%. So there is no family member affected. Can you get this type of genetic diseases without family history?
Uh, Spontaneous mutation.
Mutations are possible. So negative history does not rule out any genetic. So name another condition producing kidney disease in families. One more condition.
Uh, One more sir, families.
You would have learned in ophthalmology classes, ENT classes, entity called
Uh, Alport syndrome.
characterized by. In the ophthalmology, what's the
Deafness.
problem? Yes, in the
Uh,
neuro in the ENT is a deafness. Ophthalmology,
uh, Ophthalmology. Alport syndrome. Um, Ophthalmos.
I am just looking whether anybody can answer. Eh? Strangely enough, nobody is coming with the
Sir,
correct answer. Yes,
blue cataract.
they come with what's called as keratoconus.
Oh, sir. Okay.
What's keratoconus?
Keratoconus is irregular um, uh, thinning of cornea.
Is it thinning or is it a projection in the middle of the cornea?
Sir, it is
Conical cornea, cone shaped
chronic.
cornea, not smooth curve. It is a cone like. Okay, very good, very good. So keratoconus is a presentation, and that can run in families. Okay, carry on the history. We spent too much time on the history. Okay, carry on.
Sir. On examination, patient is delirious.
What is the diet history of this patient?
Sir, it is not given, sir.
Not given. In a diabetic patient, diet history is important. In a hypertensive patient, diet history is important. Kidney disease again, history is very important as diet is concerned. There cannot be any compromise. Okay, right.
Okay, sir.
Now, has he got any twin brother or twin sister?
Sir, family tree is not available. Not
Not. Why do you want to
accessible.
get the family tree?
To know about twinning, so the diseases may be present or
So,
any or
are you looking for a identical twin who can be a donor?
yes, sir.
Yes, sir. Yes, yes, yes. So, family tree is important in these situations where organ donation may be important. If it happen to be a disease where transplantation is the only option, then if you have an identical twin, it's the best option we can think about. So that's why we are looking for
Okay,
family history. That's very important here. Right.
okay, sir. Then the patient is lying comfortably in bed in supine position,
Mm.
not oriented to time, place, and uh, then no pallor, no icterus, no
Go slow, go slow. You are saying important points here. There is no pallor. Do you
No
expect?
pallor.
Do you expect pallor in this case?
Yes, sir. I expect
Why?
pallor
Why?
because uh, in she has been, I think, undergoing uh, dialysis
Chronic
because
kidney
she is
disease can produce pallor. Same time, you can have excess amount of erythropoietin from the kidney, as in case of polycystic kidney. You can have normal conjunctiva also. Okay, right. Then
then no pallor, no uterus, no clumping, no cyanosis, no lymphadenopathy, no edema.
before we go further, if it is a case of severe anemia in a chronic kidney disease, what drug is commonly given?
Sir, erythropoietin analogs,
And does it have any side effect?
side effect. Mm. Uh, Maybe uh,
Yes,
iron not
iron
available.
deficiency anemia. Okay, possible. More commonly, they produce headache. They produce systemic hypertension, and it can produce rarely polycythemia and occlusion of blood vessels. So, erythropoietin has got its own side effects. So, it's not given liberally; it's given only as per the standardized indications. Then only you give erythropoietin. Okay, carry on, please.
Sir, head to toe examination along
The
with the
general
face is
examination physio is head to toe. Don't say the word head to toe. There is no heading called head to toe. General examination is including everything.
okay, sir.
Yes.
General examination elongated faces are present, then protruded tongue is present, then high arch palate is present, then Lindsay nails are present,
Which is
then
percent?
sir, Lindsay nails,
Half and half nails.
yes, sir, half and half
Okay.
nails,
Okay. Right.
then brachydactyly is present,
Brachydactyly is present.
then dry scaly skin is present,
Dry scaling skin is present. So there are some clues. This may be a congenital problem.
yes, sir,
That's all what it means. There are some clues. It can be a congenital problem. Other malformations, other defects may be pointing to a congenital malformation. It may be some syndrome. Don't know. Okay. Mm.
then healed wound scar and lower limb 2 into 3 centimeter is present and
Okay.
follows normal.
Okay.
Then pulse is 80 per minute. Then um, there is AV fistula is present, thrill is present, and
Okay.
growth is present.
Where?
Sir, it is not written.
Where
Left radiocephalic.
is written there? Eh?
Left radiocephalic.
So it is a fistula made on the left upper limb for the purpose of hemodialysis.
Yes, sir.
So there's a thrill and there's a bruit. That means it's functioning. It is not blocked. Okay.
Then
The
BP is
patient is not
comfortable.
edematous, no?
Yes, sir. No, sir. Patient is currently not
Not
edematous.
edematous. So, as a renal status is concerned, it is not. There is no fluid overload. Okay.
Sir. Then blood pressure is 140/90. Then abdominal examination.
No, wait,
Uh,
wait, wait, wait. In general examination of kidney patients, you must look for scratch marks because some of the presentations will be the form of itching all over the body for CKD patients. You may also find sometimes what is called uremic frost, as if some salt is spread over the skin. Uremic frost.
First.
Okay. You must look for other limb also for the scar of a fistula that may be missing. Kidney patients commonly receive drugs like steroids. So, is there a steroid effect in general examination? You have to look for. They may be getting cyclosporine, so there may be hypertrichosis or gum hyperplasia. There may be some clues regarding some systemic disease producing kidney disease like SLE. So, such features must always look for in all cases of kidney disease. So general examination becomes a bit more relevant and important. Okay, you are going to the gastrointestinal system. Good.
Okay, sir. Abdominal examination. Abdomen is non-uniformly distended.
Blood pressure is how
Uh,
much?
140/90, sir.
Okay. Is it normal or abnormal?
Sir, it is above normal.
Above normal. For kidney disease, we expect 120/80. Diabetic patient, we want that lowering of blood pressure. It's not yet controlled. Yes.
Sir, then abdomen is non-uniformly
What
distended.
about the oral cavity?
Sir, no more details are given in
Given
the
oral cavity,
examination.
you may get large tongue of amyloidosis, or CKD itself can have large tongue, and you may get a peculiar odor in the breath when they breathe through the mouth. You may have odor in case of chronic kidney disease. Uremic smell may be there. Okay,
Okay, sir.
right.
Okay, sir.
Mm.
Then
Inspection
abdomen,
of abdomen.
uh, abdomen non-uniformly distended, left more than right.
No. Say again. Say again. It is non-uniformly distended.
Yes, sir.
Meaning by what do you mean by that?
Sir, there may be a mass in the abdomen,
Which part?
uh, in the lumbar area,
Lumbar area,
right,
left side.
left and right lumbar area,
Okay, you
left and
find two bulges in left and right lumbar areas. So what does it rule out?
sir, it ruled out uh, liver and liver enlargement and spleen enlargement.
A liver enlargement, splenic enlargement can go downwards to the lumbar area. They do not rule out that possibility, but uniform distension is the usual rule in case of ascites, and ascites also produces bulging of the flanks, not particularly localized bulge. And if it's a pelvic mass, you should have got fullness in the anterior posterior direction rather than localized in the. So it is not pregnancy, it is not a pelvic mass, it is not ascites. Just inspection tells you the two bulges on two sides of the abdomen. Okay.
Sir, the flanks are full. Mass is palpated in the left lumbar area, 13 into 6 centimeter size.
So all of you can
Another mass,
imagine how much is 13 centimeters and how much is 6. Okay.
another mass is palpated in the right lumbar area, 12 into 5 centimeter. Uh, both side of renal mass, then no, both suspicion of renal mass. I don't know. Then move with respiration, by manually palpable and ballotable. Surface and borders are regular. No medularity appreciated.
Okay.
No nodularity appreciated.
What is a border like? Sharp or rounded?
Uh, surface
No, border.
regular. It is
Liver and
smooth.
spleen will have very sharp edge. Kidneys will have rounded appearance when you palpate. Okay.
Yes, sir.
Splenic notch will be helpful to tell the spleen or not. And when you palpate, can you get above the swelling?
Sir, it is not written.
Yes. What do you expect in a kidney swelling?
No, sir. Kidney is a retroperitoneal organ.
Okay, kidneys you can get above the swelling. Spleen you cannot get above the swelling. You cannot insinuate your finger above spleen, but you can over a kidney. And these kidneys are moving, you said. Am I right?
Yes, sir. Yes, sir.
Does kidneys
Smooth
move?
respiration. The kidney smooth respiration.
Normally, does kidneys move?
No, sir. Minimal movement.
But here it is moving. So
Yes,
how will
sir.
you differentiate from kidney and liver?
Uh,
So when the patient starts breathing, immediately liver and spleen start moving. Kidneys don't move at that time. Kidneys move the later part of inspiration. Got that point?
sir.
Got that point? So these patients' kidneys will become palpable, and when you take deep breath at the end of breathing, minimal amount of movement is possible in kidneys. But liver and spleen starts moving at the beginning itself. Clear so far?
Yes, sir.
Okay, right.
No renal angle tenderness.
Okay,
Uh, then liver and spleen are not palpable.
okay.
A band of resonance is present over the lower lumbar mass.
Both sides.
Sir, it is not given, sir.
Okay, let me ask you, are the kidneys resonant usually?
Uh, no, sir.
Then why it is resonant here?
Sir, it may be colon.
A colonic band of colonic resonance will be there. So important points you must remember is resonance and the timing of the movement, direction of enlargement. Okay. So how to differentiate spleen from kidney?
Okay, sir.
Inspection, what are the differences?
Spleen from kidney.
Inspection, spleen enlarges towards the right iliac
Uh,
fossa and it moves with the respiration. Palpation, it will have a well defined edge. If it is large, there will be splenic notch and it moves at the beginning of respiration itself. Direction of enlargement will be downwards. It is not ballotable. You cannot get above the swelling. You cannot insert your finger. Okay, and on percussion,
sir.
it will be resonant in case of kidney and dull in case of spleen. And spleen is not ballotable. Okay, so you think this is possibly what?
Okay, sir.
So what's the inference here?
Sir, any bilateral renal tumor or
No, inference
polycystic
is a
kidney
kidney
disease, sir.
swelling. Inference is it's bilateral
Okay.
kidney mass. Now, what are the cause of kidney mass?
Sir, polycystic kidney disease
Polycystic kidney is
or
a good possibility.
pyelonephritis.
Pyelonephritis kidneys are not
Pyelonephritis,
palpable. Hydronephrosis unilateral bilateral.
bilateral, sir.
If the cause of the
Maybe
hydronephrosis is the bladder or down below, then you get bilateral. If it's in the ureter, okay, valvular junction
unilateral,
or
sir.
the entrance of bladder, then you get unilateral. Okay, right. Mm. Then
Then, um, sir, tumors of kidney.
tumors in kidney are usually unilateral. Usually unilateral.
Then infection of kidney, infection by pseudomonas leading to uh, air.
Infection producing an abscess, perinephric abscess. Again, it's usually unilateral, tender. The fever. Okay, then anything else? Anything else? So, your differential diagnosis, hydronephrosis versus is this patient catheterized?
Sir, it is
Not
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 given, sir.
not given. Okay. So, if it's hydronephrosis, one possibility is there, but this patient is on dialysis. So, what is more likely?
Uh, then catheter is not placed.
No, when the patient is already on a fistula and getting dialyzed, which is more likely hydronephrosis or polycystic kidney disease? Hello? 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 Fijo? Fijo? ഈ ഫ്രിഡ്ജ് ഓഫ് ചെയ്ത മോനെ ഇല്ലേ ഒന്നുമില്ല. Hello? Hello, hello.
Hello, sir.
I,
Hello.
I got lost. Sorry for that. Let's continue. So where are we
Sir,
then? We said about
sir,
we said about
uh,
the diagnosis kidney swelling, and we said the differential diagnosis possibly adenovirus versus polycystic
uh,
disease of the kidney.
kidney. Yes,
Okay.
sir.
Since there is already a what is called fistula, we thought possibly it can be polycystic kidney, although there is no family history of polycystic kidney. So, how does
Sir,
polycystic kidneys usually present to you?
sir, in adult, autosomal dominant polycystic kidney disease usually present at ages of 30 to 40. Then uh,
The question is, what are the symptoms?
symptoms: abdominal mass, then dysuria,
Why dysuria?
sir,
Common presentation: hypertension,
yes, sir, hypertension.
hematuria, frothy urine. As a chronic kidney disease manifestation, we already mentioned. Routinely you get.
Um,
Okay. So
sir,
for hypertension, is a mass lesion, hematuria, proteinuria, end stage kidney disease or CKD. You palpate the abdomen, or incidentally you may detect polycystic kidney disease. Now, what are different types of adult onset polycystic kidney disease?
uh,
Autosomal dominant, how many types are there?
I don't know, sir.
Autosomal dominant, again, there are two types: polycystic kidney disease type 1 and type 2. 75% of the people, 78-80% will be having type 1, which will be coming bit more earlier in life and bit more severe compared to type 2, which will come later in life in 60s and 70s. The cysts also appear later, and they go for chronic kidney disease also later. So when you have a chronic kidney disease like polycystic kidney disease, what are the other extra renal findings you look for? There may be some
Uh,
associations with it.
um, association.
Yes, there may be associated cysts in pancreas, liver,
Liver.
epididymis. There are multiple
Yes, sir.
cysts. Polycystic disease elsewhere. One, two.
Then acidosis.
They may have associated berry aneurysm. So
Yes,
it
sir.
may rupture, producing what is called as subarachnoid hemorrhage.
Yes, sir.
The third problem, there may be,
Colonic diverticulitis.
yes, there may be coarctation also associated, and there can be a triad. Of course, mitral valve prolapse, aortic regurgitation are cardiac manifestations. Cardiac manifestations. So, how early can you diagnose this adult polycystic kidney disease?
Uh, Sir,
At
at
the age
the
of
time of
20, at the age of 20, you wait till age of 20, do ultrasound scan, you will be, with a certain amount of certainty, you will be able to say you don't have or you have polycystic kidney disease. So you have to wait till that time. Now, polycystic kidney, we said type 1 and type 2. Type 1, which is a chromosome involved, type 2, which is a chromosome involved.
uh,
Mutation of chromosome 16 produces the classical conventional type 1, and chromosome 4 is the other
type
types
2.
of. Okay, okay. So this is how it presents, and how are you going to confirm? What are the investigations you want to do in this patient?
Sir, ultrasound.
Ultrasound is good enough if it can pick up. If you have a high index
Yes,
of
sir.
suspicion in a person, family member is affected, or the previous history is there, ultrasound is negative, then you have to go for MRI scan
Okay, sir.
or CT scan. So that is also essential. What are the complications you expect in these patients?
Sir, chronic renal failure. No, chronic kidney disease.
Chronic kidney disease, yes. Other
Then,
than that,
other than that, uh, anemia
anemia.
and
Commonly, the problems are the cyst gets
hypertension.
infected. The cysts get infected, so they have pain. So severe pain is a usual problem in these patients. Pain occur because of enlarged kidneys. Pain occur because of infection. Pain occur because the cyst may bleed into the cyst. It can produce problems, or the cyst may be pressing upon the collecting ducts, producing stasis. Stasis predisposes for stones. Stasis predisposes for
Yes.
infections. Stones predispose for infection. So this is a vicious circle. Okay,
Okay,
the
sir.
cyst
Okay,
becomes
sir.
large. They produce pressure effect on the blood vessels and produce ischemia. So renal system is angiotensin converting enzyme is involved. Renal angiotensin is stimulated, and you get again hypertension, and this vicious circle keeps on continuing. Okay, so
Okay, sir.
how are you going to treat these patients?
Sir, uh, for hypertension, diuretics,
You just
agent
control their
indication.
blood pressure. That's the only thing that we can do when you detect it early. Subsequently, when they go for chronic kidney disease, as we are doing in this patient, patient is on renal replacement therapy. If there's infection, you treat with the antibiotic. If there's a bleeding, it may stop spontaneously, or you may aspirate. Okay, and if there's pain,
Okay, sir.
you give symptomatic treatment. If the patient can afford, in course of time, patient may be helped by getting a renal transplantation.
Transplant.
That is also possible in these patients. We discussed about the donor being a identical twin. So when
Twin.
a polycystic kidney disease is an identical twin, the correct person to donate.
Yes, sir.
It is not, because that person may also have the same mutation. So in this situation, you have to go for genetic studies. Okay,
Yes, sir.
genetic studies. And if there's history of subarachnoid hemorrhage, then you have to go for MR angiogram and do clipping for the same. So this today's case is to highlight that this is a good short case for you. Bilaterally palpable kidneys, you must be able to tell why it is not kidney, why it is kidney and not spleen or liver, and what are the causes, and look for the associations, and then know a little bit about the fistula and chronic kidney disease. Okay,
Okay, sir.
what genetic counseling can you give?
Sir, in autosomal dominant cases, we can tell about the uh, probability of transmitting the
No, we can
disease to
only say probability, but you screen the other family members till the age of after the age of 20 years to say whether they are affected or not. Now the question is, will you transmit it to next generation?
sir, there is a 50% probability.
So how will you identify them and save the next generation?
Sir, by genetic studies, by mm, uh, gene typing,
Gene typing of what?
chromosome number 16 and chromosome number 4.
No,
Like
this person is already affected, so his genetic study will be abnormal.
the fetus, sir.
Then if it is affected, you terminate, is it?
Uh, uh,
What is your advice?
no, even if affected, the child is can live up to age of
No man,
uh, 15 to
pre-implantation,
16.
pre-implantation genetic study. You got the point?
Okay, sir. Okay,
That's
sir.
right, that's what is done. If at all you have facilities, that's what you can do. Okay, probability will
Okay,
not
sir.
help in a single individual. Affected person is asking, will my child get it? How can you say 50-50? That is not acceptable. So there's option available in this matter. Now I think it's good enough, well presented, very good. Okay, thank you.